Certain drugs produce hyperthermic clinical syndrome either when taken in overdose or as idiosyncratic reactions. This talk will explore some of these drug-induced hyperthermic syndromes that you may come across in your practice. So at the end of this talk, you'll be able to identify the drugs associated with iatrogenic hypothermia and describe the clinical features of the following hyperthermic syndromes. So let's start with our first case. A 34-year-old female who has depression presents to the emergency department with agitation and confusion. She's flushed and sweaty, and her temperature is 39.4 degrees centigrade. Her pulse is 148 beats per minute, blood pressure 148/67, and she's also noticed to be hyper-PER reflexic. Just pause the video and see if you can figure out what's going on with this patient. So this is typical of serotonin toxicity, or serotonin syndrome, often seen in patients with serotonin reuptake inhibitors, or sometimes seen with these patients. They tend to have neuromuscular, autonomic, and mental status changes, including hyperreflexia and myoclonus, high PER hyperthermia, tachycardia, and agitation and confusion. In fact, the Hunter serotonin toxicity criteria helps to identify these patients. And this flow diagram takes us through the steps of the Hunter criteria. Notice the emphasis on clonus, high PER tonia, high PER hyperpyrexia, and high PER hyperreflexia. The second case is a 36-year-old psychiatric patient who has taken an overdose of his medication. He's confused, agitated, with warm, dry skin. His pupils are dilated, he's tachycardic, and his blood pressure is a bit on the low side. Then, while in the department, he has a grand mal seizure. Again, stop this and think about whether you've seen a patient like this and which syndrome this is. So this is the anticholinergic syndrome. Patients present with hypotension, tachycardia. They may have a prolonged QT interval and are prone to arrhythmias. They also have altered consciousness and are susceptible to seizures due to cerebral irritability. Their pupils are often dilated. Other symptoms include urinary retention, dry skin, dry mouth, and mildly increased temperature. The cartoon on the right is another way of remembering these symptoms. They're as blind as a bat, as mad as a hatter, as hot as the desert, dry as a bone, as red as a beet. Case 3, a 24-year-old man with chest pain. He's pale, with poor perfusion and sweating profusely. He's somewhat confused and agitated. His heart rate is 145 beats per minute with a blood pressure of 196/105. Pupils dilated but reactive to light. And his temperature is 38.9 degrees centigrade, so he's pyrexic. Pause the video, have a think of which syndrome this might be, which hyperthermic syndrome this might be. Apologies. This is actually the adrenergic or sympathomimetic syndrome. The cardiovascular effects include tachycardia, hypertension, vasoconstriction, and chest pain. They have dilated pupils and may be agitated and delirious and may suffer seizures from the overdose. Patients also have a mild to moderate hypothermia, peripheral vasoconstriction, and are prone to rhabdomyolysis. Again, the cartoon on the right gives a more pictorial representation of these signs. A 78-year-old man, psychiatric patient, presents to the emergency department 2 weeks after continuing his anti-Parkinsonian medication. He's been on haloperidol for the past 2 years. He's confused and agitated with a temperature of 40 degrees centigrade and a pulse of 132 beats per minute. He's also diaphoretic and is noted to have lead pipe rigidity of his arms and legs. Pause the video, think about what this might be. So this is what is seen in neuroleptic malignant syndrome, often, seen in patients who are on antipsychotic medication, usually within a few weeks of starting the medication, but can also be seen in patients who were on a Parkinsonian medication and may have withdrawn that medication abruptly. These patients tend to be tachycardic, agitated, with a resting tremor and lead pipe rigidity, dystonia, and dyskinesia. They are also hyperthermic, and the temperature can get quite high, diaphoretic, and are prone to rhabdomyolysis. The cartoon on the right takes us through some of the clinical features in a pictorial form. Finally, a 58-year-old male, 24 hours after having a general anesthetic, he presents to the emergency department with a temperature of 41.6 degrees centigrade, low blood pressure, fast pulse, and occasional runs of ventricular tachycardia on his ECG monitor. Again, pause the video, think about what this might be, come up with some answers. This is malignant hyperthermia seen after the use of some inhalational anesthetics, was particularly common with the use of halothane, but can be seen with other inhalational anesthetics. It is an inherited disease, condition, autosomal dominant with variable penetrance. Patients present with tachycardia, arrhythmias, often ventricular, a labile blood pressure, muscle rigidity, which has been described as similar to rigor mortis, masseter spasm, hyperthermia more than 41 degrees centigrade or a rise of more than 1 degree per 30 minutes, hypoxemia and hypercarbia due to the hypermetabolic state that they're in, and metabolic and respiratory acidosis. So we've talked you through several hypothermic syndromes that you might come across in the emergency department. If you have any questions, you can post them on the discussion board on the website. In summary, this table shows us the key clinical features for each of these hyperthermic toxidromes that we mentioned earlier.